person. Thanks everyone for coming to the second in-person Mirror ICH Grand Rounds. This is an effort to continue the conversation in person when we can, hybrid at other times, about what the ICH space is doing, what's the hot stuff happening, and where we need to go from here, and trying to share details about the procedure and about patient care to continue to move the ball forward between the announcement of major studies. And so it's our great honor today to have Dr. Magdy Salim visiting from Harvard. He is professor of neurology at Harvard Medical School, Beth Israel Deaconess. He's also chief of the Division of Stroke and Cerebrovascular Disease. He started his medical training in Alexandria University in Egypt, and then came to Massachusetts, where he did his internship at Brockton Hospital, and then his residency in neurology at UMass, and finally his fellowship in stroke neurology at Beth Israel, where he's stayed since. He has been a major thought leader in the ICH space, leading some of the major trials in our space, including the IDEF trials, the Saturn trial, which is active, evaluating statins in ICH, and many others. So we're very happy to hear him talk about the future directions, given that he's played such a major role in getting us to where we are now. Thanks very much, Dr. Magdy Salim.
Thank you, Chris, for the kind introduction and for having me here. It's nice to meet everyone, and it was great to meet everyone last night too. I first really want to applaud you for organizing this series. I think it's very good to bring all the ICH community together, our surgeons, neurologists, ED physicians, everyone. I think that's really great. So these are my disclosures. Probably the most relevant one is that I'm not a neurosurgeon. I'm a vascular neurologist. So sometimes I'm a little bit critical and might have different opinions, but that's the purpose of this, is that we can have a discussion and see how we can move forward. So we'll start again. Is this, oh yeah, this is working here, okay. You want me to try? Okay, you can hear us on Zoom? Okay. Okay, good. So thank you everyone on Zoom too. So I think what I wanted to do, we're fortunate enough, maybe really the field of ICH is relatively new and not as extensive and as old as research in ischemic stroke. So we have few major trials that I think shaped what we're doing now and where we are going from there. And what I wanted to do is share with you what I learned from these trials and how we can use this to move forward. And I wanted to really focus on 4 areas: blood pressure lowering, hematoma expansion, hematoma evacuation, and secondary injury after ICH. So let's start with the blood pressure lowering, and many of you are familiar with the 2 landmark trials that we have for this, INTER-ACT2 and ATTACK-2. One was done mostly in Australia and Asia, and one in the United States and China. The first one, INTER-ACT2, early intensive blood pressure lowering within 4.5 hours from hemorrhage onset, showed really a marginal improvement in long-term functional outcome. There was some improvement, but it's not huge. ATTACK-2, unfortunately, there was no benefit. Early blood pressure lowering did not help. However, when you start looking closely at the data and doing post-hoc analysis, you can see that within the INTER-ACT2 study, if people are able to lower the blood pressure by 20 points within the first 2 hours, these are the patients actually that tended to benefit the most. And the same thing actually with ATTACK-2. If you're able to reach the goal blood pressure within the first hours, you can see that this results in reduction in hematoma expansion and improve in functional outcome. And this is INTER-ACT-4, which was a little bit different. So it pushed it a little bit earlier. Why don't we lower the blood pressure in the ambulance? So they did it for any stroke, not just hemorrhage. Any patient with suspected stroke, they lower the blood pressure. And it turns out at the end that overall, it doesn't matter. It does not improve outcome. But if you start looking at the stroke types, it hurts people with ischemic stroke, but actually it was beneficial in patients with hemorrhagic stroke. So what I'm showing you here is that there is something to say about starting treatment early in patients with intracerebral hemorrhage. Same thing when we talk about hematoma expansion, and many of you or the older group may be familiar with the FAST trial, and this is factor 7A, which is a hemostatic agent. This was really probably the trial that got the field moving and interested in ICH. And this basically was administering hemostatic therapy within 4 hours, did not really result in improved outcome. It did reduce the hematoma expansion, but there was no improvement in functional outcome. Similar study, but using a different agent, which tranexamic acid. This was done mostly in the UK and other parts of the world. Again, showed no benefit. However, this study, they started the treatment within 8 hours, not 4 hours, so even longer. And very few patients were treated within 3 hours. Now, if you start looking closely at the data and some of the other studies that were done after that, something called Spotlight and Stop It trial, which basically looking at would the effect of hemostatic therapy differ if people have a spot sign on the CTA or not. You start really, when you're looking at the time here, you're starting to see sort of an obvious trend. In patients who are treated within 2 hours, you can see that you can reduce hematoma expansion by around 6 cc. If you extend this to 3 hours, it drops to half of that. And then after the 3 hours, almost really you see no effect. And the same thing when you look at the functional outcome, you can see that the earlier you treat, the higher the proportion of patients who achieve good functional outcome. So the story is starting to come together that time really is important when we treat these patients. And here are the 2 ongoing studies. One of it, I think you are part of it, which is the fastest, which is basically trying to administer factor 7A in the ambulance within 2 hours. And it even requires that half of the patients are treated within 90 minutes. So a very aggressive goal. And there is another one using tranexamic acid again in the UK, which is trying to move to treatment earlier. I told you in the first study used 8 hours. Now they're doing it at 4.5 hours. I'm not sure it's early enough, but you can see that people are starting to push the boundaries and start the treatment early. So what have we learned from these trials and blood pressure lowering and hemostatic therapy? I think it's really clear that we should start thinking about hemorrhage the same way we think about ischemic stroke. Time is really important and every minute counts. And I think this has important implication, not just in how we triage the patient and how fast we treat them, but I think our whole system of care around hemorrhagic stroke, I think need to change to match what we do for ischemic stroke. Now we'll move on to your favorite topic, I guess, which is hematoma reduction. And I don't like to call it hematoma evacuation because we never really evacuated completely. There is always some blood left. So you're all, of course, familiar with the MISTY program and the MISTY 3 trial. This is like the landmark trial that looked into this. And of course, there was lots of hopes, but we were all disappointed that at the end, there was no improvement in outcome with the MISTY approach. So the question here becomes why? Why didn't it work? Is it time or is it the technique? And the reason why I say that, because in the MISTY 3 trial, the median time from hemorrhage onset until they made sure that the hemorrhage is stable to be able to administer the therapy, it was around 36 hours. So that's a day and a half. That's a very long time. And the median time from onset to treatment to starting actual treatment was 72 hours. So that's like 3 days. And even in some patients, it was up to 134 hours. I'm not sure how many days that is. It's probably like 5 days or something like that. Not only this, but also only around 60% of the patients in MISTI 3 reached the volume that they specified or pre-specified that they want to reach at the end of evacuation, which was 15 mil. And interestingly, the majority of patients in these trials had lobar hemorrhage and not deep hemorrhage. And you'll see why in a second this is relevant. But the question becomes, why only 58% of the patients achieved this target reduction of 15 mil? Is it the surgeons? They didn't do a good job? Is it the technique? And I think when you look here, the answer is, I think, is pretty obvious. So you can see that 32% of the patients that had the MISTI approach developed what was called asymptomatic rebleeding versus only 8% in the placebo approach. So it's almost a fourfold increase in rebleeding. Now, whether you call it symptomatic or asymptomatic depends really on how this was defined within the context of the trial. But the way I see it, you start with someone who had a 30 cc hemorrhage. You took 15 out, they have 15 cc. They bled again, it became 20. Their NIH stroke scale is not going to change much within a day or two. So you would call it asymptomatic, but the truth is they rebled. And probably the rebleeding is because of the use of TPA. At least that's my own interpretation of it. So my own interpretation of this is that because they had to use a thrombolytic agent, they wanted to make sure that the hemorrhage is stable. You have to get a CAT scan. And we saw on average that takes a day and a half. And I think what we learned from this is that to be more efficient and to achieve more effective evacuation, you probably need to do it early and you want to avoid the use of thrombolytic agents. So this is an interesting study from China looking at the different strategies that are available for hematoma evacuation or reduction. Surgery, MISTI-like approach, or doing endoscopic evaluation. Now, interestingly, this is a randomized trial. You don't see a placebo arm in it. It's all just comparing one surgical approach to the other. Those of you who have been in China, you know that if you don't do surgery on a hemorrhage patients, the family will kill you. So it becomes really a logistical problem not to include a placebo arm. But what they found in this trial is that probably the best outcome was achieved with endoscopic evaluation. After this, with a MISTI-like approach, and coming third is just a routine surgical approach or craniectomy. So probably that justifies Enrich. And of course, you're all familiar with Enrich, and was very exciting for the field, especially after MISTI 3, to see something that's promising and showing positive results. And you know that overall the trial was positive, but mostly driven by lobar hemorrhage, and enrollment in the deep hemorrhage part was stopped prematurely because of perceived futility of continuing there. So the question here, we reverse it now. Why did it work? Because that's what you want to learn from it. So is it because of the time? Because in this trial, it was only enrollment up to 24 hours, and the median time from last known well to starting the surgery was around 16 hours. So it's a lot faster than 72 hours that we see in MISTI. So is this a factor? Is it the technique or the device? They did not use thrombolytic agent. They used the brain path system and the Myriad suction system. I think, I'm not a surgeon, but I think a lot of people probably don't think it's the device or the technique, but it could be. Is it the statistical design? And they use kind of a novel design that a lot of us don't understand very well. But if this is a good design, maybe that's something we should adopt going forward. I think there was a novel aspect of it that I think is actually important to use, which is the enrichment component of it, is that you look and see where you expect to get the highest benefit, and this is the group that you focus on. Makes the trial more likely to succeed, and of course you focus your power and your number of patients on this trial. So I think this part of it is certainly beneficial. Is it the way they define primary outcome and they use the utility-weighted modified ranking? And I'm going to talk a little bit more about this. So what do we know about the utility-weighted modified ranking? We were talking about this last time. So it's basically people always criticized just modified ranking alone because that's a way of just telling you the functional outcome for the patient. But it doesn't really capture in a component how the patient themselves perceive how well they are doing or how not well they are doing. So by tying the two together and incorporating quality of life assessment together with the modified ranking, you get a better idea of patient centric outcomes or how they perceive how well they are doing. So in this trial is enrich, we saw that the difference was 0.08 when you look at this utility weighted MRS, which is basically across a score of 1, the difference was 0.08. So I personally struggle with knowing what this means, 0.08. So the only thing I could do is go back to the other stroke trials that use the utility weighted modified ranking. And the only other trial that did this was the DAWN trial, which is thrombectomy trial in ischemic stroke patients. And in thrombectomy, which was a positive trial, the difference was 0.21. So it's a lot higher than the 0.08, but since I don't understand what either one of them means, I'm just looking at it and saying, looks like a very small difference compared to this. But we're talking about very different diseases. And of course, maybe effect size is different of the different interventions. So I dug a little bit more to see what utility weighted actually means. So this is a study that looked at all the interact protocols, and they have many trials, and it was routine for them to do modified ranking and to collect quality of life assessment. So they asked the question, if we reanalyze all these studies and we use the utility weighted modified ranking as the outcome, what happened to these trials compared to when we use just the modified? And what they found is that the utility weighted actually seems to match what the ordinal distribution of the ranking would be. And not only this, but there is a huge benefit in terms of sample size. If you use utility weighted, the trial is much smaller than if you use just the regular modified ranking, even cut the sample size by almost half. But the interesting thing that they found is that how patients perceive how well they are doing actually differs. So if they move from 5 to 4, they think that's a huge improvement. If they use from 4 to 3, they think that's also a big improvement. But in the upper areas of the modified ranking, if they move from 3 to 2 or 2 to 1, for patients that they did not perceive this as a significant improvement in their functional outcome. So there is a little bit of a problem because maybe at the lower edge of the ranking is different than the upper edge. And what this study concluded is that the best thing is to look at a real study, simulation study, and see what happens. And that's what Mr. Clean investigators did. Again, it's a thrombectomy trial. They decided to look, was a positive trial. Will the outcome change if we use utility weighted instead of modified ranking? Now, for them, it did not work. So if they use the utility weighted, Mr. Clean would have been not a positive study. What's that? Yes. Yeah. So the big question is, so the utility weighted really part of it, as I said, is quality of life. And how people perceive their quality of life depends on a lot of things: family support, culture, maybe even the type of stroke. We assume that all strokes are the same, but people with hemorrhagic stroke, mortality is high. They might be happy that they're just alive. Someone with ischemic stroke may not be happy that they're using a cane or a walker and they want to walk. So they're not really exactly the same. And when the Interact group looked at this, you can see that when you apply these weights, that they're actually not the same. the utility-weighted modified Rankin for ischemic stroke is different than for hemorrhagic stroke. You can see the differences here in red. And they seem like small differences, but don't forget that we're only talking about one. So this is like 1% of 1, 0.27 of 1. So there are differences. Now, this is another study to try to look at this variability and how actually we can adjust for it. And really what they concluded is that in order for your utility weighted to achieve the purpose it was developed for, it will have to be trial specific. It will have to be done within the same cohort of the study, done prospectively and concurrently. You don't bring it from another study and apply it to one study. I see one thumb down, but I say I like that. So all grabbed it from Don, and that's the problem. And I think part of the problem too is that when you so Don actually, yes. Yeah. So Don used the one that where just the utility weighted was developed and this was done mostly in the UK. And it's actually not necessarily for stroke patients. So it's just applying weight disability and see what it is. Correct, Jay? Was it? Yeah, sure. Yeah, I mean, the numbers are just an arbitrary thing. Yeah. Yeah, I mean, you can see it here. So at least we identified a controversial topic that we can talk on. But so let's go back to enrich. So we know that the basal ganglia, it did not work, but did it really not work? So why not? Is it the technique or the device? Is it the residual volume? Is it rebleeding? We know the basal ganglia is highly vascular and maybe rebleeding risk is higher. Is it because the basal ganglia is very close to the ventricles and there is IVH that maybe affect the outcome? A lot of these things we really don't know the answer to because at least they have not been published yet. And I'm just focusing on what has been published. Maybe it will come and we'll have the answers. But the good news is that we have a recent meta-analysis, including Enrich, and Chris is one of the co-authors on this, where they looked at the major trials that have done in this area and concluded that minimally invasive evacuation showing benefit. Now the question is, Enrich only went up to 16 hours. Can we go earlier? And the first question that comes in, is it safe to go earlier? And we do have the answer that it is safe. And this is the Dutch group that evacuated the hematomas as early as 6 hours. And there was really no major safety issues there. So my take on this is that what we have now is very encouraging and very emerging. I'm actually in favor of evacuation, but I think to do it right, we need more data. We need more evidence. I think endoscopic evaluation is probably the way to go. I personally think that we need probably additional data to be comfortable with the lobar hemorrhage. And we clearly need more data for the basal ganglia hemorrhage. We cannot say that it didn't work based on very few number of patients enrolled in. And I think that, like everything I showed you in hemorrhage, the earlier the better. I think it's the same thing here. Now, if we want to use utility-weighted MRS, and I mentioned the advantages, clearly cutting a trial sample size in half will make it a lot easier to do it and complete trials. I think just we as a community really need to come up with what we think is the utility-weighted MRS for hemorrhagic stroke patients validated. I think we have not done this yet. So I leave you here with a lot of more questions than answers when it comes to surgery. Do we need different devices and approaches for different locations? Is very early evacuation better, and how early can we push it? How much residual blood can we tolerate? Does this vary by location or not? I think it's probably more complicated than this, but this is one thing to look at. And another question, like, when do we go for surgery? Is there a threshold, a cutoff? People started with 30 cc, dropped to 25, dropped to 20. Does the volume vary between lobar hemorrhage and deep hemorrhage? So there are a lot of things that we need to tweak, but I think people are starting to look into these questions. Now, the last couple of minutes, just quickly talk about the secondary injury. And this is the IDEF trial with deferoxamine, and the primary endpoint, which was the difference in modified Rankin 0 to 2 at 90 days, was negative. It was not a positive trial. However, when we look at 6 months, and on top is IDEF and on the bottom is enrich, and I want you to compare this ordinal distribution of the Rankin between these two trials. Looks very similar to me. So why is one considered positive and the other one considered negative? I think part of it is that in IDEF, we define this as a secondary outcome, not a primary outcome. But that's also true for an NH. So that was not the primary outcome. But I think really the figures, at least to me, they look very similar. Taking into consideration it's a different population, the volume of hemorrhage is probably different, all these patient characteristics. Now, the reason why we saw a difference in IDEF is this graph here, which is very, so on top is placebo, on the bottom is deferoxamine. What you see is the proportion of patients that were independent after 7 days, after 30 days, 2 months, after 3 months, and after 6. And you can see both of them, the curve keeps going up. And basically what it tells you is that hemorrhage patients continue to improve over time. And I think what we learned from this is that when you look at 90 days, it's early because we're seeing that patients are improving past the 90 days. So there is continuous improvement in hemorrhage patients, and the 90 days is too early. The other thing that's interesting here is that how fast people get better, how fast people achieve independence. And if you look at the bottom compared to the top, you can see that a larger proportion of patients become independent sooner. I think that's probably important because it can save money, important for quality of life for the patient, for the caregiver, but it's something we really never use in our stroke trials or in our hemorrhage trial. I started thinking about this after COVID, when they were looking at just simple intervention to decrease the length of hospitalization. And that was the primary endpoint for some of these stuff. The same thing in MISTY and CLEAR 3, you can see that patients who were really in bad shape at 30 days, and you follow them, and after a year, a lot of them are doing better. So it just, we need patience. Now the question becomes, so when do we look at the outcome? Clearly not 90 days. Is it 6 months or is it 1 year? I think it's probably 6 months is sufficient or in between, because what you can see here is that most of the changes happen up to 6 months, between 6 months to a year. It's actually, the change is not that big. If you can do it at 9 months, maybe that's sufficient. Another thing we looked at in IDEF is, does the volume of the initial hemorrhage matter? And it is really what you expect. If the hemorrhage is very small benefit that you get from the drug. The hemorrhage is very big, no benefit from a drug. It's almost like a drop in an ocean. It's not going to do anything. If you focus on the medium-sized hemorrhages, the odds of improvement is 2.7. So this is something I think that's where the enrichment design would come in, and to try to select the patients who are really likely to benefit. So what did I learn from this? I think we have learned all as a community that the 90-day assessment of outcome is probably premature in hemorrhage. We need to go beyond that. I think what I showed you is that I think a pharmacological approach is not completely out of the window. It's still there. But it's very important that any trial that we are aware that if there is a huge variability in the size of the hemorrhage, that can dilute the effect that you're looking for. So if you have a lot of small hemorrhages and a lot of big hemorrhages, then you're putting patients that you just know from the beginning that they're not going to benefit. The group that's likely to benefit is very small, and that's what we need to. So for the future, I think I highlighted that time matters. I think enrichment design, I think something that we can definitely use. I just pose a question whether the time to achieve independence should be something that we look at. I don't know how this would affect sample size, but to me, it sounds like really an appealing endpoint. And we mentioned last night is that our problem was hemorrhage trials, that it's a very small number of patients. And without having many countries participating in them, it's difficult to compare. So here is my concluding slide and what I think really the future will be. So we all realize that time is important and it will become more obvious. So the patient ambulance goes to home. And what's missing in the link, which I think really the one thing that's missing to drive the field forward, is diagnosing ICH in the field. So whether you do this by some portable sort of imaging or biomarkers, and there are stuff going on, you know that it's a hemorrhage, you start blood pressure lowering, you reverse coagulopathy. If hemostatic therapy works, you give them homeostatic therapy, you bring them to Mount Sinai, see Crescent J, you do minimally invasive evacuation, reduce the volume. I think smaller volume always will be better. And then on top of that, there will be blood left no matter what you do. So there is always room for some pharmacological intervention to target the secondary injury. So it really to have to be a multimodal approach. I don't think one thing is going to do it. And I think to get the best benefit, it will have to be all of them. And then once you're in, I think you can do whatever you want administering inside the brain. I think Chris and Jay know this. I've been interested in actually hydrogel therapy, which is enriched with anti-inflammatory agents and nerve growth factors. And at least in animal models, we see that this can result in improved outcomes. So once we can prove that surgery works and we master this, I think the future will be something along. Thank you. And if you like to travel, come to Sydney.
Thank you. Thank you so much, Magdy. Why don't we have questions for the group discussion? And so I'll invite down to the stage Brian Jankowitz, who's a cerebrovascular neurosurgeon from JFK. Yamako, of course, cerebrovascular neurosurgeon here, participate in the discussion, and Fernando Carvalho Juarez, a neurocritical care attending here at Mount Sinai as well. And we'll continue the discussion for about 20 minutes.
I was told there would be no exams.
So we'll pass around these two. Sakina, is that Zoom working or the video? It's on. You can see us. Okay, great. Well, that was an awesome summary, and there was a lot of good fodder for discussion there. I loved your slide about Enrich results, and I noticed that the only individuals cheering were surgeons. And so cheering neurologists. So I wanted to ask, what do you think is what's your interpretation of the impact of Enrich thus far, and what do you think the field at large how it will be received over the next year or so? Basically, should we revise guidelines based on what we have? Is more work needed?
That's a tough question. So my interpretation, to be honest with you, Enrich reminds me of like ACAS4. Remember when we're trying to extend the time window, and the effect size is very small, but I think the community needed something to build on to move the field forward, and we did. So I think to me, Enrich looks similar to that. We really needed something to get the field moving, and it's encouraging results. That's good. I I'm not sure for me that these are like definitive trials. I'm used to like a little bit larger trial than this to call them a phase 3. A 200 patient trial for me is still to some extent I would call it a phase 2. And then we have this disagreement about the end point, whether the utility weighted and we know what it means or what we don't know what it means. But I think overall, the field, I think I've seen like people adopting variable ways about it. You guys have adopted it. Some other places have adopted it, but I don't think all the places have adopted it. And some people blame it on the neurologists, but I don't think actually that's true. It's also part of it is the surgeons. I think some surgeons want to see more. Some surgeons want to settle on the issue of time before coming up in the middle of the night and doing that. And then there is also a big question about, do we really have to use the specific device and technique, or can we just do it? And what I heard from a lot of surgeons is that this is like stitch 2, but doing a different approach. So not exactly the same, but some people say that, and some people want to stick to the old way of doing things. So I think there's more to do, but it's certainly something encouraging that we can build on and we should build on. You asked about the guidelines. I think the guidelines probably will come up with some very cautious words about how to interpret this. This is encouraging level of evidence, maybe somewhere in the middle. And so it's not going to completely shut it down. It's not going to completely give it thumbs up. You're on the get with the
Yeah, I think, well, there were so many things there. I don't know if I can remember all the things I wanted to say in response. I think that on one level, there's the question of what's changing the community's behavior, and the other level is where do we think the evidence lies and where does it sit? I think that when you look at it's important, I think Enrich by itself, just a 300 patient randomized trial would be very convincing, but non-definitive. However, when you look at also the positive trials of Pentansis and the much smaller, I understand they're peripheral because they're so small, but the more concern is Zuccarello, but Pentansis 108 is a pretty legit number. I think you're now talking about close to 450 patients that have been randomized or a little bit over, all with signal of benefit. So I find that pretty convincing for Lobar. I think there's still enough question for the deep bleeds. And to make sure I'm clear, for those other trials, they did include deep bleeds as well. So it's not, but I think the signal that we see in Enrich is clear. In terms of the type of approach, I just find it hilarious because living through 2015, 16, 17, and the massive battles that went on about whether you needed to specify that a stent retriever was explicitly used for thrombectomy because that's the way it was done. And therefore you had to say that was the way it needed to be. This was a fight that I fought quite vociferously and lost. Therefore, ran a prospective randomized trial in Compass, got that published and changed the standard. But that was, it's so funny to me that the same community that insisted that since the trial uses technique, you had to use this technique, now says, nah, it probably doesn't matter. You can use any approach you want. And so I think if I were the Enrich investigators, if I were Nico, that would bother me. Obviously, I'm a fan of a different approach, but I do, it's interesting sort of the Jekyll Hyde nature of the way these things get interpreted. And then, lastly, I'll just end on the analysis. And I think that the broader community is looking for a reason not to do this versus the analysis really being that obscure. When Enrich was presented at AANS, Adam Arthur gave the commentary afterwards, and he put up a number needed to treat number. That's all we need, right? So a number needed to treat for thrombolysis for cardiac intervention, something like 45. Number needed to treat for PCI, percutaneous coronary intervention, something like 15 or 16. Number needed to treat in dawn and diffuse, which you showed had a 0.2 improvement, is about 2.5. Okay. The number needed to treat based on the enriched results for an improved functional outcome, that's the way you would say it, is 11. 11's pretty darn good. That's the same as for clipping a ruptured aneurysm, according to Adam's chart. So I'm referencing his work. I didn't do it myself, but that's pretty powerful in the panoply of therapies we provide people. And so the idea that many of my good friends are out there saying this is confusing and we're not sure, I think it's a communication issue. It's a messaging issue. I think if they had just put in the conclusion of their abstract the number needed to treat or something that helped people understand the narrative, we wouldn't be having as much a debate as we're having. That's my mind.
Let me ask Fernanda, how is the neurocritical care community receiving this trial?
I think my impression, being in meetings and speaking with other neurointensivists is that they definitely think the results showed, was very clear for lobar hemorrhages being a good intervention, but there's some concern about it being like a specific device, like in whether how translatable it's going to be with other approaches. And also would like to see more data, but I think everybody's very optimistic that more studies are going to confirm that surgical intervention is probably going to be the future of ICH treatment. And it's gonna, right now medical management is very limited. What we can control blood pressure. We have to kind of do it very early, and reverse coagulopathy has to be done very early. A lot of patients don't come in that early. We also want to see if there are other medical management, like maybe interventions that can reduce inflammation, for example, that can also benefit patients. And I actually think that there's an opportunity to also look at patients who get surgery and those who don't have evacuation, and kind of like look at if biomarkers change, if there's any markers of inflammation in the brain that's different between both, because that might help identify targets for patients who are not eligible for surgery.
Talking about the body of evidence that is growing to support this field. I'm sorry I was late, but I didn't hear you comment on MIND. And to have another recently published randomized controlled trial just presented within the last 3 months, I'm just curious how you think that changes your perspective, or what did MIND add to the body of data that already existed, particularly in the post-enrich era?
So it's a little bit like asking me what I think about California, but I only drove to Iowa because mine enrolled about a third of the target patients that they were supposed to enroll. Included in that population were thalamic bleeds that were subsequently excluded, but were included to some degree, and included enrollment out to 72 hours. And we don't have those details yet from the trial. But we have, if you include MIND, if you include Stitch 1, Stitch 2, and MISTY 3, we have about 2,500 patients in prospective randomized trials that did not require intervention less than 24 hours. And all of them show no signal of benefit. We have 4 trials with 450 patients looking at intervention less than 24 hours, and all of them show signal of benefit. To me, this is one of the strongest narratives through this. Time matters in heart attack, matters in ischemic stroke, matters in ICH. And when you just look at that fact, 4 trials, 450 patients less than 24 hours, all positive. 4 trials greater than 24 hours, 2,500 patients, all negative. I think that's what it tells us.
Something else we saw in MIND was a fairly dramatic disparity in improvement in the operative group versus the medical management group that washed away after 30 days. And we saw this in Enrich as well to some extent. To make shorter, faster, cheaper trials, should we maybe stop thinking about whether 12 months is better and maybe move that outcome metric down to 30 days and just look for an early signal as a positive finding in ICH trials, particularly as we start operating even earlier, where we might see an even greater disparity in the early outcome that then just for a variety of reasons gets washed away?
So again, that's another tough question. So not surgical trial, but TITCH3, that tranexamic acid in the UK. So their primary endpoint is 7-day mortality. Now, okay, okay. So the question is, are people would be happy with that with such an early endpoint? So there's something to be said about you want to make sure that when you're doing an intervention, especially that it's expensive, that there is a long lasting benefit, I guess. So the 30-day is a little bit tricky. And I think most of the patient know that we show. So any trial, especially if you do surgery, I think probably the 30-day outcome would be better in the surgical group, maybe, because you're decreasing mortality, you're getting them out of the ICU, you're avoiding all of these complications. But I think at the end, we're still interested really how the patient does. It depends on how you want to look into it. It's just a different way of thinking about it.
I think it's a great question because so if your question is how do patients ultimately do, clearly it's not. And if we're talking about going to a regulatory agency or something like that, they're not going to be interested in a 30-day outcome. However, if an outcome was ICU length of stay, hospital length of stay, cost of care and other things, then you might see a meaningful difference that would potentially affect regulators.
Case, right? ICU stays.
Yeah, but I think we need to get surgeons excited about this patient population and this treatment paradigm, because to your point, neurologists are my biggest supporters. They've been in Pittsburgh, at Penn, at Cooper, and at JFK. And neurocritical care has also just absolutely been incredible supporters of surgical evacuation of ICH. The problem in the United States, it's the neurosurgeons. And in this gilded institution of Mount Sinai, you just can't possibly know what's going on in the community where no one wants to operate on ICH. And there are 100 different reasons that I can give you, many of which are out of my control. The OR refuses to accommodate me. I have to bump my own partners who have an 8-hour spine surgery, which is lucrative for the hospital. I mean, a lot of external influences that make it difficult. And until we make it sexy for a surgeon to operate and give them more meaningful short-term metrics, I just worry that we're going to keep fighting this issue.
Just send out more videos of Kellner operating.
I am carrying the torch. I am, but it is tough, and it worries me.
It was
that
a
the
sexy
neos-
reference. It was a sexy reference.
No, but I mean something like Enrich and other trials to come to show. I think all you need is just really to get them excited, is to show more positive results, and
they're just never going to do as slap you in the face benefit and do that.
but
Look,
you're never gonna get a slap.
Right. This isn't ever gonna be sexy. And I'll give you the perfect sort of counter example is the large core trials. We now have 6 prospective randomized RCTs that show clear benefit, and no single trial is perfect. I love it. I hear it all the time at the meetings. People pick at this trial that has a problem or this trial has a problem, but across the breadth of all the studies, there's clear signal of benefit, and yet the community is finding every way in which to not do it, and that's not even dealing with the OR. So the reality is when you're dealing with a patient population that isn't, you don't have those hole-in-ones, those Lazarus effects, those dramatic improvements that we get with the early case population, and you're dealing with generally a very disabled population, it's very hard to get the community to find it, to become enthusiastic about it.
Yeah. Well, again, I'm not a surgeon, so I don't know how you guys think about it. But it's not like because surgeons don't want to come in, because the truth is most of the surgeons are also people that do endovascular intervention.
I disagree.
No,
In the outside of most academic institutions,
it's not the case.
the average neurosurgeon operating on ICH, which is an issue. And I think we need to figure out, does that make sense moving forward? Should we consolidate it? And should it be just as cerebrovascular surgery, or should we democratize it to the average, not the average, but a general neurosurgeon?
Oh, actually, I mean, I didn't talk about this when I said systems of care. That was my point, so that these patients really should be shipped immediately to a comprehensive center.
Yeah, I think that brings up another topic that's really interesting given the Interact 4 results. Should we transfer ICHs directly to a CSC, Or do we have data that that might be deleterious and controlling blood pressure as quickly as possible for ICHs? So diagnosing them, getting that blood pressure controlled is the most important thing. Then bring them to a CSC. So curious to hear what you guys think about that.
I'm glad you asked because I was intrigued by your slide too. That something you really want to push as an agenda item is earlier diagnosis of ICH, which always struck me as irrelevant because usually the smaller hospitals want to get rid of ICHs and get them to CSCs as fast as possible. But I'm curious if you had something else in mind about other avenues of early intervention, whether that be hemostatic agents or neuroprotectants in the ambulance, which I also agree. Stopping hematoma expansion is every bit as important, if not more, than evacuating the hematoma when it expands.
Yeah, so I mean, the problem was the new interventions that we don't have anything yet. But yes, if there is something, I don't see why you do not start it in the ambulance. So we're always taught to think that the secondary injury takes a few days and you have time. But actually, that's not true. There is a lot of data now from animal studies to show that the hemoglobin toxicity starts early on. And there is an early phase, it becomes maximum later on, but it starts the minute the hemorrhage happens.
Early pre-hospital administration of a neuroprotectant, or is that just something?
For hemorrhage?
Yeah. Okay.
It's not neuroprotective.
The hemostatic agent, yeah, but yeah. Yes.
Like right now, we need imaging to diagnose it versus like, I think a biomarker. It's like blood sample.
Serum biomarker.
Yeah, there's a lot of data on GFAP and
Yeah.
stuff like that. The problem is that I think any of these things are not going to be 100% sensitive in detecting hemorrhage, but at least we know that you get the majority of the decent sized hemorrhages, you'll be able to identify them, I think.
We've got a few questions from the Zoom audience here. And I think we can hear you if you speak. So I see Wendy's eye had a question. Are you able to, let's see if can you unmute and ask? And here we go.
Can you hear me?
We can hear you.
Yes. All right. Thanks, Magdy, for a great presentation. Really enjoyed these controversial topics. So I just wanted to make the point, MISTY 3 was 62% deep, 38% lobar, exactly the opposite proportion of enrich. And when we did the utility weighted MRS analysis for MISTY, we also got a significant result for benefit of surgery, even at a late, it was late surgery. That's the way it was designed. And that was true as well for the deep hemorrhages when we looked at deep versus lobar, which compares to a negative utility weighted benefit for the enriched trial. So I'm not sure maybe there's an opportunity for different procedures in different locations, but I was really getting back to time and the way that we move from very early to much later time intervals for thrombectomy. Do you think that we still need to explore time as a wide open field, because we're likely not in the future going to exclude patients just because they come in after 8 hours or after 24 hours? And do we still need to study that later time interval?
Yeah. I mean, I'll take a quick shot while you get it together. I think you're totally right, Wendy. I don't think we necessarily, as a field, want to exclude people from all windows of time. But like we did if we had started the thrombectomy trials looking at the broader inclusion criteria, we likely would not have been positive. And it's a little bit of an indication. An example of that would be IMS3 that started without using CTA diagnosis and other things. And so we need to build momentum. I think, the meeting we had on Saturday, Sham was saying, and I think he hit the nail on the head, is really doing targeted maximal benefit populations, small, early, all the right things so that we get that positive signal and then we build on that the way the ischemic community did to eventually get it across all windows. But I agree, we're not going to, I certainly am not looking forward to a world where we say, oh no, sorry, you came out after 12 hours, we're not going to try to help you. I think that should be something we're trying to do. The question is how do we maximize our potential signal right now to create that momentum? But I think you're totally right, and I'd strongly support, as a field, not closing down our minds to certain time windows or certain presentation statuses.
So I was going to say the same about you really kind of want to put your money where the most benefit would be. So yes, so you want to capture the ones that you think most likely to benefit. So you start with early and then you try to expand it. I think after 24 hours, so now we have maybe encouraging evidence from enriched for the 24 hours. I'm not saying that everyone will have to be done within 3 or 4 hours, so you can extend the time window within that. But most of the hemorrhoid patients, they come in within the 24 hours. So if you go after this, you're missing very, very small number of patients. I'm not sure we need to worry about that now. But I think, yes, up to 24 hours, I think it's important for us to see what the distinction is during these different time periods.
Great, thank you.
I think with that, we're going to have to call it. We've got some room restrictions here, but thank you everybody for coming and also signing on. Thank you, Magdy, for traveling down from Boston. Really appreciate it, and look forward to seeing you next time.